Okay, we are now officially recording, so we are good to start. I am going to start by sharing my screen. I can post this PowerPoint as well, but just to kind of keep me on track and make sure I'm covering everything that I would like to cover. So hold on just 1 minute while I share my screen. That one. Okay. All right, so hopefully everybody can see my screen. Let me just kind of move some stuff down here so I can get going. Okay. All right, very good. All right, we're going to go ahead and get started. When I'm on the full screen, I can't always see the chat box, so I will stop periodically just to make sure I'm hitting the questions in the chat box as we go through. You can definitely tell it's a Friday. Okay, so U6C1 Zoom class. Before we get started on today's stuff, there were 3 areas of the previous exam, the Unifier exam, that I wanted to review. And the first one related to heparin infusions, because heparin infusions apply to Unit 6 as well, because depending on the provider's preference, they may use a heparin drip for select patients who are experiencing an ischemic stroke. That does kind of vary based on the provider as to whether or not they will actually go with heparin or they'll go with something else. But it is a possibility. So heparin infusions will apply to Unit 6. Everybody was really good on their math. They plugged in the numbers. They did the math correctly. The biggest issue for students that missed the heparin question, they did not round the weight, okay? Per the protocol, and it's in the protocol, I want to say number 2, maybe in the protocol, or number 1, where it talks about, for adults, rounding the weight to the nearest 10 kilograms. So if you didn't round the weight, if you went with the exact weight, that was going to make your heparin bolus off by some. So if you missed the heparin question, that was generally the reason that you missed it. The other thing I wanted to kind of hit on was ABG interpretation. And not so much how to interpret the numbers, because I think overall the class is really good on that. They can look at the numbers and they can determine if it's, you know, respiratory or metabolic. They can tell if it's acidosis or alkalosis. I just wanted to kind of refresh on the compensation piece, but then also connect it to the actual patient situation. Okay, in somebody with a chronic respiratory disorder like COPD, okay, their numbers, you know, for their PCO2 and their bicarb are always going to be abnormal. They're always going to be out of whack because it's a chronic condition that the body is trying to compensate for. So for somebody with stable chronic COPD, they are generally going to have a fully compensated respiratory acidosis. Their pH generally will run right at like 3.75, maybe 3.76. It's probably not going to get a whole lot higher than that. And of course, their PCO2 is elevated. So that's the acid side. The bicarb is elevated, trying to balance everything out. So they're going to have a fully compensated respiratory acidosis. That's your stable chronic respiratory disorder patient, and your COPD patient would be an example of that. Now, when you have somebody that has a chronic condition and it's not stable, okay, maybe they're starting to show signs that they're declining, or perhaps they're experiencing an acute exacerbation. They are still going to have a respiratory acidosis, but at this point, it would only be considered partially compensated because the pH level will now be completely acidotic. It's not going to be within that normal range, just leaning towards acidosis. So I just wanted to clarify that. Again, students that missed that question, I think that's where the confusion was, really differentiating between somebody who is a stable chronic somebody with a respiratory disease and somebody that has something acute going on, okay, and the ABG results that went along with that. The other question that students really seem to struggle on, and it was about half and half, about, you know, half of the people got the correct answer, the other ones kind of went for what I would consider the next best answer, but they missed the first step of the nursing process. So there was a question related to a medication, and it talked about the patient having overdosed on the medication or taken too much, and what would be the nurse's priority action. And there were some action interventions related to, giving a certain antidote. There were some action interventions related to like client teaching. The correct answer related to assessment. And in this case, it was a medication that we monitor using a lab test. So remember, your lab values are part of your assessment. Monitoring blood pressure, monitoring for signs and symptoms of bleeding, that's part of your assessment. So if your patient has taken too much of a medication, you always go back to the first step of the nursing process, and that's assessment. For this particular patient, if they overdosed on something, maybe they do need an antidote. We don't know that yet. We don't have enough assessment data to determine that, yes, that's the appropriate course of action, because everything that we do is a benefit versus a risk, decision. So if a patient has taken too much of a medication and we're monitoring them and they're not showing signs of compromise, they're not showing signs of a decreased blood pressure severely, they're not showing signs of excessive bleeding, it's quite possible that monitoring the patient very closely is what we want to do first. We don't necessarily jump the gun and do something that may not be necessary. Another example of this would be your patient reporting nausea. Okay, your first action should not be to go get the Zofran from the Pyxis. Okay, you need to assess that first. Why are they nauseous? What's going on? Are they nauseous because their roommate decided to empty their colostomy bag and it stinks? Zofran ain't going to help that. Okay, so it goes back to that first piece, the assessment, before you take action. Now, as a caveat, it depends on how the question is worded. Is there enough information provided in the question that you can truly draw a conclusion and say, yes, we need to do this? Okay, that's really going to be the determining factor of whether we talk about, are you looking for an answer that's focusing on assessment, or are you looking at an answer that's focusing on, okay, we know what's going on, we know enough, it's appropriate to take this action. Okay, so I just wanted to clarify those three concepts in particular. Not that the group did horribly, but those three items I think tended to be a little bit more challenging than others that people had some trouble working through. So that's why I wanted to address that. Okay, let me just check the chat box to see if we have things that are specific to this. Okay, that's Unit 6. Okay, vital sign stroke, okay. Can I tell us the answer for I don't have the question in front of me, but if you got it wrong, it was because the math was correct, you put the wrong weight in. That's where students had messed up with that. The ABG question, it was the question asked about a stable chronic COPD patient. Okay, chronic obstructive pulmonary disorder patient. So it was the ABG values that showed the fully compensated respiratory acidosis. Assess and monitor. Okay, very good. So those words can be used interchangeably as an action word. Yeah, so that's always something that people kind of question, but the reality is you as the RN performing an assessment, that is something that you're doing, okay? That's something you're doing. Now, that being said, that's why when I talk about you doing your CP2 and your interventions, you always need to have assessment monitoring interventions, and you need to have action interventions. Certainly if I'm treating a patient with a respiratory disorder, I need to have at least one intervention that focuses on, a focused respiratory assessment. Otherwise, I'm not going to be able to trend how my patient's doing, okay? So when you're looking at it from an NCLEX question perspective, that goes back to what is the question asking, okay? And in that case, it was asking what was the priority action by the nurse. Sometimes that priority action is further assessment. Sometimes I know enough from what's there that I'm okay to go ahead and act, okay? But again, for that particular question, it was talking about the patient had too much of a particular medication. Okay, so we knew that they had too much of it. What we didn't know at this point was, does the patient truly require a reversal agent versus ongoing monitoring as the priority action? Okay, now certainly had that question been worded in the sense that the patient had overdosed on the medication and their gums are bleeding, they just vomited, you know, bright red blood, we have the information to be able to act. At that point, the reversal agent is the priority because the patient is, you know, exhibiting signs of toxicity, not the possibility of toxicity, but true signs of toxicity. Okay. And just to comment on the assess versus monitor, not that this question looked at it, but if we were talking a scope of practice conversation, assess is an RN buzzword. Monitor is something that can be done by an LPN or an RN, but monitor generally refers to LPN scope of practice. However, in questions, they, you know, when you're talking RN, if it's not a question focusing on delegation, they are used interchangeably. If they weren't showing any signs, why would it be called an overdose? Because they took more than the dose that was prescribed. They still have overdosed on the medication. Now, whether that's a toxic overdose that exhibits symptoms or not, you know, that's where the assessment piece comes in. So like, for example, let's say I got up this morning and had a headache. I want to take some Tylenol. And I meant to take 2 Tylenol because they were 500s, and for some reason I took 3. At that point, I took an extra Tylenol. Am I going to go into liver failure? Probably not with 1, depending on if I have underlying liver issues and all that sort of thing. You know, so you're looking at it that way. What I would need to do is monitor myself to see, you know, am I having extra effects? You know, what do I need to do? Now, if I would start showing signs, I'm looking in the mirror and my skin and my sclera are turning yellow, yeah, I need to take immediate action. So that's where we kind of look at it. You know, every action has an equal and opposite reaction. So if we give an antidote or a reversal agent when it's not truly needed, we could go swing the pendulum in the opposite direction. So a patient may be on an anticoagulant to prevent the development of blood clots. Okay, well, if I hit them with the antidote when they're not showing signs of active bleeding, I can then swing the pendulums too far the other way that they're spontaneously making clots, and now they're at risk for a DVT, a PE, a heart attack, stroke, etc. So you're always looking at the benefit versus the risk. So that's why it's still considered an overdose, but you need to do that further assessment to determine, okay, what direction do we need to go in? It's always about patient safety first, but every action that you do, every intervention that you do has to be really based on patient assessment. And that's why if it goes back to foundations. If your assessment is incomplete or if it's accurate, you're then making decisions based on incomplete or inaccurate information, and that can cause harm to your patient. So good questions, good discussion. Let's see. Okay, when someone overdoses on narcotics, we administer Narcan right away. We do that because at that point they are already showing signs of respiratory depression. Okay, usually by the time we get to somebody who's overdosed on a narcotic, their respiratory rate is like 4, 6, something like that. And we need, right there, we need to act immediately. I'm not going to continue to monitor somebody that has a respiration of, you know, 4 to see, well, maybe they're going to pull out of this. At that point, 4 is not life sustaining. Okay. And certainly they might live through it, but they're going to have some brain damage. So at that point, there's enough there for us to act immediately. Yeah, so I guess a rounding question. If it was 35, you would round to 40. Yeah, so it's 5 and above, you round up. If it's 4 or less, you round down. Let me see here. How can assess and monitor be used interchangeably if LPNs can only monitor? Unless the question is mentioning an LPN and it refers to delegation, RN, we use those terms interchangeably. If the question is asking about the RN or if it doesn't specify, you can assume it is the RN. At that point, they're going to be used interchangeably. If it's asking about delegation or the question refers to an LPN, then be aware of that monitoring buzzword, because monitoring does mean watching trends and that sort of thing. So in the case of an overdose, we wouldn't have the time to watch the trends before deciding to get an antidote or not. It really depends on the medication. If you're talking something that has a long onset of action, yeah, they're not going to crash right away unless it's a massive overdose, and that was not indicated in the question. This goes back to the basic NCLEX premise of you need to assess your patient first before you can determine a course of action. And at that point, this patient, yes, had taken more than the allotted dose of the medication. However, they were not showing signs of cardiovascular compromise. They were not showing signs of respiratory compromise that would warrant immediate action. So at that point, you need to assess the patient. And for this particular medication, there was a lab value that is used to evaluate that. So the correct answer was getting the lab. Now, based on the lab result, we may act. Maybe even before the lab result comes back, the patient starts showing signs of compromise. We would act, okay? But at that point, we did not have that data that provided the basis to give a reversal agent, okay? So going back to that basic, that assessment piece, that you need to assess your patient fully so you know what action to take. Again, if you walk into the room and the patient's not breathing, I am not doing a full head to toe assessment. I need to rapidly support oxygenation and perfusion. Okay, so that kind of goes back, those types of questions, if you struggled with that one, that's where nurse logic would be very helpful in looking at how to approach those types of questions, particularly the section on priority setting, but also foundational knowledge, critical thinking, and clinical judgment. That is the big piece. When we talk about making tougher decisions like that and really picking between those higher level questions, we're referring to clinical judgment. And there is a section on ATI Nurse Logic that specifically looks at clinical judgment. I am going to point out that I did run a group report on who has looked at Nurse Logic since the Unit 4 exam in preparation for Unit 5. Those of you that did, thank you very much. And I think it was helpful to you. Those that didn't, that is definitely something that I'm going to recommend. It was probably, I could count the number of students on one hand who had done that. And that is something I strongly recommend because it will help you not only with the Unit 6 exam, the final, it will help you moving forward in preparing for NCLEX. Okay, another question. So can we assume all of the information given in the answer choices are valid information based for the patient situation? If it's a question where it's asking what is the priority, what should the nurse do first, that sort of thing, yes. NCLEX principles, all of those options are to be viable, and it is what you would select first, okay? Now, I may give a reversal agent, but if I give a reversal agent that doesn't apply to the particular med that they overdosed, is that going to be beneficial to them? No. So you have to go by what's in there. But again, when you're looking at priority, this goes back to, do I need to assess further, or do I have enough information at this point that I have to act? Okay, so if you haven't been on the Nurse Logic, and some of you, when I ran the report, haven't been on since fall of 2019, you know who you are. I would strongly recommend that you get on there before the next exam. And honestly, before you even get back on Prep U, I am going to make another custom practice exam specifically for Unit 6. Because students said that they found that very helpful. I think it will be even more helpful if you look at Nurse Logic before that. Okay, so you can apply those principles. All right, moving on to today, let's take a look at the quiz. There was a typo on the quiz. Trochlear was supposed to be on there. Apparently it was trigeminal, and I didn't pick it up. So I have to manually go through everyone's quiz to make sure that the points are correct. So posting of today's quiz grades is going to take me a little bit longer. It'll be later on tonight because I want to make sure I get it right. As for content, for taste discrimination, that relates back to the facial nerve. Pupil response relates back to actually 3 cranial nerves, the oculomotor, the trochlear, and the abducens. That was the one where the typo was there. So all students will earn credit for that because that was an error on my part. The watch tick test relates back to the acoustic nerve. The gag reflex goes back to the vagus nerve. The Snellen chart was the optic, and shrugging of the shoulders tests the spinal accessory nerve. The other 4 pieces were matching, and it related to expressive versus receptive aphasia. So I want to talk a little bit about this because when we talk about aphasia here, we're talking about an issue with expression, an issue with language. So when we talk about expressive aphasia, I can understand what you're saying to me. I can understand it. My brain is processing it. I'm processing it accurately, okay? But expressive, I can't select the correct words. I can't get those words out. I have a problem with expressing language, okay? So you might tell me that, you know, Girl Scout cookies are still on sale and I want a box, and I'm expressing to you something about a bluebird, or I might not be able to speak at all, okay? So expressive aphasia, your patient has issues expressing what they want to say. It can be verbal. They might have issues expressing, you know, in writing, like in actual handwriting, but they know what you're saying. They can process what you're saying. They just can't express their response. A little bit different than receptive aphasia, okay? With receptive aphasia, you're talking to the patient and what you're saying to them makes absolutely no sense, okay? Their brain cannot process it into a coherent thought. So you can speak to them even in short, simple sentences. They're not really processing, they're not understanding you. Now, we talk about them as 2 separate things, but it is quite possible that your stroke patient may experience both, okay? And that's what we would call global aphasia, where they're experiencing aspects of both of those. Now, hemiplegia versus hemiparesis, okay? Difference between weakness and paralysis. So hemiparesis, okay? Paresis refers to weakness. Hemiplegia refers to paralysis. So if you think about somebody that has a spinal cord injury and they're a paraplegic, they've lost feeling, motion, movement from the waist down, okay? It's para because it refers to 2. Here, it's hemi because it refers to one side of the body. So when we're talking hemiplegia, they have paralysis on one side of the body, either the left side or the right side. When we're talking paresis, that refers to weakness, okay? So again, it's hemi, so I'm referring to one side of the body, unilateral, but that's weakness. Now, as you learned about, as you are prepping for today's class, you know that a stroke is going to affect one side of the body, okay? It also affects the opposite side of the body. So when I talk about somebody that has a right-sided thalamic hemorrhage, okay, so they've had a hemorrhage on the right side of their brain, they're gonna see the weakness on that left side of their body, okay? And vice versa. If the damage, if the clot, if the ischemia, the bleed is in the left side, the hemiplegia, the hemiparesis, I'm going to see on the right side. Okay, so just to clarify that. All right, so let me see. Are there any questions about the quiz? Let me just look and see on here on the chat box. Okay, so stroke AVM. Okay, we'll get to that as we're going through. Okay. All right, very good. All right, so just to hit, starting with neuroassessment, just hitting some key points. And what you probably noticed as you were going through the capture video related to the anatomy physiology assessment piece, there was a lot of stuff in there that you probably don't routinely do with your everyday general nursing assessment. It's like any other body system. There's things that we hit consistently with every single patient that we're taking care of. Doesn't matter what the diagnosis is, you're always looking at level of consciousness and orientation, okay? You know, you're always looking at essentially motor function grossly. You're looking at their gait, their balance. We make you, as part of your clinical assessment, assess muscle strength and actually have you graded on the 0 to 5 scale. But for a nurse, a generalist working on a med-surg unit, if they're not in for a musculoskeletal issue, they're basically looking to see, can they move all extremities? Are they exhibiting any generalized muscle weakness? Is there any difference from side to side or upper to lower? Okay, so it's a much more general assessment. You're looking at gross function. Whereas if you have a patient with an actual neuro issue, this patient is coming in with a stroke, you know, change in level of consciousness, rule out CVA. You're getting much more in depth. So in looking at this, these are things that you might not be doing on an everyday basis, depending on what patient you're taking care of. But if you would get a patient with a specific neuro disorder, these are things that you need to be aware of. So level of consciousness, you should be very familiar with that. I do want to comment on, just because I've been reviewing all the narratives for CP2, well, you use the abbreviation AAO, okay? That stands for awake, alert, oriented, okay? And then you can add the, you know, to person only or ×3, you know, whatever. Awake, alert, and oriented. So going back to the COPD case study, he definitely was awake. But if you noticed when the nurse Allison was interacting with him in that first video clip where they were interacting together, he was very slow to respond. He wasn't asleep. He wasn't, you know, really difficult. So I wouldn't necessarily call him lethargic. I don't think he really is to that level, but he certainly wasn't alert either. So just be careful when you're using abbreviations. If you're using AAO, that means awake, alert, and oriented. So just kind of watch that. The other thing I have up there is GCS, the Glasgow Coma Scale. You know, it's stuff that we are assessing all the time, but we don't necessarily throw it into the Glasgow Coma Scale. But we look at their level of consciousness. We look at their best verbal response. So are they able to respond? Are they making sense? And also we look at their best motor response. So can they follow commands? Do they reflex to pain? Are they showing signs when we apply painful stimuli of posturing? Either decerebrate posturing where they're posturing out, or decorticate posturing where they're posturing in, okay? Typically, you're seeing posturing, we're looking at a very, very serious neurological condition. We're now seeing, you know, a very low Glasgow Coma Scale. It may be related to trauma. It may be related to a brain tumor, bleed, that sort of thing. But if your patient is posturing, we're in big trouble. Is posturing similar to contractures? It looks like contractures. Like when you see a patient posturing in, like this would be decorticate posturing because we're in towards the core, whereas decerebrate, they're extended and they're kind of out posturing. So the decorticate posturing, position-wise, it looks very similar to contractures, but that posturing is generally in response to a painful stimuli. Whereas a patient with a true contracture, that's there all the time, whether they have painful stimuli or not. Very good question. Obviously, orientation, you're familiar with, you know, person, place, time, situation. Language, we talked about a little bit in relation on the quiz to the expressive and receptive aphasia. But language also refers to the clarity. You know, is their speech garbled? Is it clear? Maybe it's not even speech at all. It's grunts or inappropriate words. Okay. So you're looking at that. You're also looking to see, does it make sense? And that kind of goes into the cognition piece, that basic thought processes. But are they saying things that make sense? Are they using inappropriate words? Or are they just stringing words together that just don't go together? You know, the bluebirds driving the school bus. I mean, that makes no sense. With cognition, certainly memory, you assess this a little bit with your basic interaction. Certainly long-term memory, you know, you can kind of get from their name if they're talking about, you know, when they were kids, if you're asking them about that psychosocial stuff. Short-term memory, if they can remember who you are, you know, remember seeing me this morning, I came in and gave you meds. Attention, you know, is there a difference in their attention span based on their baseline? Okay, I know a lot of people that have no attention span whatsoever. Okay, that is their norm. That is what they typically do. You're basically looking to see changes from their baseline. Basic thought processes, you know, again, are they stringing thoughts together? Are they able to follow what you're saying? You know, follow those basic commands. Abstract thinking, you know, the garbage can is on fire next to you. What are you going to do? You know, how would they respond to things like that? Also looking at their mood, looking at their insight and their judgment. You're really going to see changes with this, particularly with stroke. And I go back to my own personal experience. Some of you, I've shared with you that my dad had a hemorrhagic stroke in September of 2016. And he's come a long way since then. He's done, you know, a great job with the recovering. But for some things, his judgment is just not there. We literally have had to place the phone away from him because if he would answer the phone during the day, you know, there's lots of scammers out there, you know, and some phone calls, solicitation phone calls may be legit. But honestly, if he would answer the phone, he would agree to give money to whoever called him. Okay, so he does not have the insight and the judgment to be responsible, or what I would say competent, to make financial decisions. He is competent to make decisions about his health. You know, we can talk to him about a new medication. We can talk to him about a test or something we want to do and be able to talk through that, and he can ask appropriate questions. That's okay. But for his insight and judgment related to financial matters, absolutely not. So when you have somebody who has a specific neurological dysfunction, you know, this is why we do the much more in-depth assessment. And again, as a nurse generalist, this is not something you're doing all the time. Reflexes, probably the biggest one that we always look at is your gag and your swallow reflex. If your patient doesn't have a gag reflex, if they can't swallow appropriately, the risk for aspiration is there. So that one you guys are well versed in. You've been doing it every week when you were taking care of patients. Deep tendon reflexes, those are the ones with the reflex hammers where you're hitting certain areas of the body and you're looking for the muscle, the nerve sensory response. Sensory motor response. You know, again, not something as nurse generalists we're doing all the time. There are some areas where you will do deep tendon reflexes a lot. On OB, you know, some of you are having your maternal newborn class in the fall. On OB, if we're treating an expectant mom with magnesium sulfate, either to treat pregnancy-induced hypertension or preterm labor, those deep tendon reflexes, as the magnesium level goes up, will diminish. So OB, they check deep tendon reflexes a lot, looking for a side effect of that potential treatment. I do want to say a word about the corneal reflex, and I want to be very clear that you never, ever, 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 ever check a corneal reflex on a conscious patient, okay? If you take a look back in your fundamentals book or even in your Hinkle Med Surg where it talks about how to assess corneal reflex, you are taking a wisp of cotton, opening your patient's eye, okay, and touching the cotton to the cornea to see if they have that natural reflex of blinking and moving, okay? That is not something you would ever, ever, ever do on a conscious patient. Quite frankly, you wouldn't even get that close to my eye to be able to do it. That is something you're gonna have on an unconscious patient, ICU level patient with some significant brain damage. Certainly sensory perception, and that can vary from, is your patient able to feel you touching them, to the presence of paresthesias, the numbness and tingling, to temperature sensory perception. So, you know, if you put something that's cool to the touch there, can they identify that, or warm to the touch? You know, we talk about the lack of sensory perception, like in our diabetic patients that experience diabetic neuropathy. But the same sensation, the same concept is there for your stroke patients. Motor function, we've talked a little bit about that. Certainly coordination. When we look at their movements, when we look at their gait, we look at their balance, but we look at them moving, are things coordinated? If you look at how somebody naturally walks, you know, how things flow together. Or you look at a patient clapping, you know, that coordination of the two hands coming together. You can see some issues with that in your stroke and your neuro patients. Certainly muscle strength, you know, that we talked about, the generalized weakness, that 0 to 5 scale, but also muscle tone. When we talk about flaccidity, that muscle is completely flaccid. It's not going to move on its own. It doesn't even contract on its own. Versus, you know, your muscle weakness versus spasticity, where you're having actual spasms. Okay. And then, of course, the cranial nerve testing. Again, that's not something as a nurse we're typically doing all the time, but you do need to be aware if we're suspecting a problem with a cranial nerve or a problem in the brain area where the cranial nerve is located, they might assess one or more cranial nerves. For example, you know, if they have a tumor in the occipital lobe, where we're thinking it's going to, you know, affect vision, that sort of thing, they may do the cranial nerve testing. So just to kind of review that a little bit. All right, so let's move right into, well, actually, before I do that, let me open up the chat and let me just go through and see if there are any questions related to assessment. Okay, okay, that's related to stroke. Okay, lumbar puncture, that is related to, okay, I'll talk about with stroke with that. AVMs is stroke. Let's see here. Oh, what is the ATI module called? You were referring to the pre-class capture for neuro assessment. Oh, it's actually the physical assessment of the adult. And when you get inside there, it's broken down by body system. So you would go into the neuro piece of that. Let me just see if there's anything else related to neuro assessment. And if not, we're gonna, okay. Okay, all right, we are good. All right, so let's get into the different types of strokes. And this is critical for you to understand, because what we do treating the underlying cause is going to be determined by what type of stroke it is. There's going to be things that we're going to do for a stroke patient regardless of whether it's ischemic or hemorrhagic. But when we talk about treating the underlying cause, that is really going to be determining on what type of stroke it is. So an ischemic stroke, there is a blockage, okay? A lot of times there's plaque buildup. This tends to happen where the arteries bifurcate or they split. So you can see on the screen, you have that artery and then it's splitting then into two, it's bifurcating. That tends to be where plaque really builds up and you can get that blockage right around that bifurcation. So there's usually a lot of stuff going on that's contributing to this. So you can have the plaque buildup, and as a clot is tiny, it's moving through. It was moving through fine until it got to the area where the plaque was built up, and then it stopped. You can also have a clot that forms someplace else in the body and then travels up to the brain. That's also considered an ischemic stroke, but it's considered an embolic stroke. Very similar to our pulmonary embolism, where it started in the leg and from the DVT and it worked its way up. So it's an embolus, okay? So what you need to understand is what you're seeing on that screen is essentially the same exact thing that happens with a pulmonary embolism, okay? There is a blockage and it's blocking the blood flow behind it. So the same concepts that we talked about with a PE are now occurring, but we're talking about it in the brain. So the area that is distal is not getting adequate blood flow. So in the brain, wherever that blockage is, all of the area that is behind, or not behind, ahead of that blockage, where that vessel would feed, those cells are now becoming hypoxic because they do not have the blood flow, they do not have the oxygen delivery, and they don't have the ability to exchange the CO2 back into the vascular flow. Okay, so it's very important to understand that everything beyond that blockage is going to be hypoxic. Okay, and eventually, if we don't fix this, depending on how large the clot is, depending on what vessel we're talking about, is this in a major vessel affecting a large area of the brain, or is this in one of the more smaller vessels that is affecting a more localized area? That's going to determine what signs and symptoms you see, and it's going to determine ultimately the deficits that your patient's going to be left with. Okay. So that's your ischemic stroke. So things that would put somebody at risk for an ischemic stroke: anything that's going to increase plaque in the arteries, anything that's going to put them at higher risk for developing a DVT or a clot. I mentioned before in the last unit, atrial fibrillation, okay? When you have AFib and the atria are just simply quivering, they're not contracting to push the blood into the ventricle for the ventricle to then push it out, that blood is kind of pooling and is sloshing around. So patients with AFib are very prone to clot formation, which is why if you have a patient with chronic AFib or it's intermittent AFib where they're going in and out of it, they will be on anticoagulant therapy to prevent clots, okay? Because what we're worried about is a clot forming in the atria, moving to the ventricle contracts, and if you think about it, the left ventricle, every time it beats, 25% of the blood that it ejects is going right up your carotids into your brain. So if they are not anticoagulated, they literally are a 1 in 4 shot of having a stroke with every heartbeat. Okay, so this is serious. The other thing that happens, a big risk factor for strokes, both hemorrhagic and ischemic, we'll get to hemorrhagic in a minute, is hypertension, because generally hypertension is going to cause damage to the inner lining of the blood vessel. So what that does is it makes the vessel less compliant. So it's harder for it to vasodilate, vasoconstrict, but it also creates an environment where the plaque is more likely to build up. Same thing with your diabetics, particularly your uncontrolled diabetics. Those macrovascular changes we talked about in Unit 4, it predisposes them to plaque buildup. It predisposes them, it makes, you know, their blood essentially is a little bit more sticky. So it makes it easier for those clots, those platelets to get attached to those plaques. So those things are major, major risk factors for strokes. If I had to pick the top one, I mean, they're all bad. What our research shows us is the #1 factor that is going to influence the risk for a stroke is blood pressure, is uncontrolled hypertension. That is the number one risk factor for strokes. And if your patient can do anything to reduce the risk, getting that blood pressure under control is going to be key. Okay. Now, flipping to the other side, a hemorrhagic stroke, here you have a rupture in a blood vessel, and that blood is spilling out into the brain tissue. Okay, so it's hemorrhagic stroke. Now, if you just stop and think for a moment, if you know, let's say you're shaving, okay, shaving your leg, shaving your face, whatever, okay, you're shaving and you cut yourself. The reason you don't bleed to death is because platelets get activated. They go to that site where the bleeding is happening and they plug up the site. And for that to happen, you have clotting factors and you have the platelets, okay? That's what keeps you from bleeding to death. That is what your body tries to do with a hemorrhagic stroke, okay? It's going to activate the clotting cascade. It's going to activate the platelets, and the goal is to plug up the bleed, okay? So it's very important that you understand that, because when we talk about treatment, there are certain things that we do for ischemic strokes that we can't do for hemorrhagic strokes, because if we did, your patient would rebleed. Now, obviously, just like a regular scab, just like a regular plug, it is not as stable as intact skin or an intact vessel, which is why your hemorrhagic stroke patients are at risk for rebleeding. Okay, the reason that this ruptured in the first place 9 times out of 10 is because of the blood pressure. The high blood pressure caused that rupture. Okay, so it's very important to understand those different types of strokes because it really guides us into treatment. All right, let me check out the chat box here. ABGs be used to identify this type of stroke since it creates hypoxia. They could do ABGs. Honestly, that's not our priority assessment at this point. You know, we know at this point if they're having neurological issues, there's something going on there. We need to identify what type of stroke it is. And then at that point, we support oxygenation and perfusion. So depending on the patient's level of consciousness, if they're completely unconscious, they're not breathing on their own, this patient's going to need to be vented. Okay, and at that point, we would be doing ABGs, not to manage the stroke itself, but to guide us with the vent settings. Okay, but good question. Yeah, the cells become hypoxic. That's what happens up there. And what the issue with the stroke is, you know, those cells become hypoxic, and when the cell dies, it releases the substances that are inside it, all the, you know, the cytokines, the different things, the reticoplasmic, whatever from AMP, the potassium, that's an intracellular ion, gets released there. So then you have problems with that. So what starts as perhaps a small blockage can then cascade out. So when you talk about the cascade factor with strokes, that's what they're referring to. All right, so now that we've talked about the 2 different types, let's talk just briefly about expected findings. There is a pretty widespread campaign educating people on stroke, and it's pretty good. They use the acronym FAST, F-A-S-T. That's what they use for the public. The F for the facial drooping, the A for the arm, but it's talking about numbness or weakness. Again, that unilateral piece. One-sided weakness, one-sided paralysis, either the left or the right. Ataxia refers to difficulty walking or, you know, inability to walk. The S refers to speech difficulties. Okay, maybe it's aphasia that they can't speak, or it's dysarthria that they're speaking but it's slurred. And then of course the T refers to time. In healthcare, we actually use the acronym BFAST. So every time I see that commercial on there, I'm like, no, it's BFAST, because the first thing we look at is balance. And with a patient who's suffered a stroke, it kind of goes along with the A, that numbness, that weakness, but their balance tends to be off because of that weakness. The other thing is the eyes. They can experience vision problems. Sometimes it's blurry vision. A lot of times it might be that they can't see out of the one side of their eye. Depending on what other symptoms they're having, they may or may not be able to communicate that to you. So it's really important when you look at a patient and you're looking for facial drooping. Now, the commercial that they show on TV is very obvious that that woman has facial drooping. I mean, honestly, you know, I would say somebody with really low vision wouldn't be able to miss it. Sometimes that facial drooping is very subtle. So what you want to do is ask them to smile, ask them to puff their cheeks out. For somebody that's having a stroke and has paralysis or weakness on one side of the body, when they smile, their good side that smile will be able to go up. The paralyzed side or the weak side won't move at all. That is also considered facial drooping. So you need to be aware of that. It's not always the classic picture on TV of what facial drooping looks like. Other things that you're going to see, confusion. They're just whiffy. They're not making sense. Certainly an altered level of consciousness, they may go completely out. One of the things that is very classic for hemorrhagic strokes is a very sudden, severe headache. A lot of times they'll even report it as the worst headache they've ever had. And that headache is specifically because of the increase in intracranial pressure. I'm going to go back to the previous slide because I failed to mention this back here. But you can see how your hemorrhagic stroke there, that blood is bursting out and getting into the tissues there. Okay. Um, you know, your brain is, you know, enclosed by your skull. So when you have an increase in the pressure, okay, there's really no place for that swelling to go. You know, if I overturn my ankle outside, there's room for that ankle to swell. In the brain, because of the skull, there is not room for it to swell. So as the pressure increases, it's going to start essentially pushing pressure down on the brainstem. So that increase in pressure is what causes that classic sudden onset headache that we tend to see with hemorrhagic stroke. That increase in pressure, if it gets really high, is also the reason we will see projectile vomiting in somebody with increased intracranial pressure, whether it's from a hemorrhagic stroke from the bleeding, or if it's from something like a traumatic brain injury, a motor vehicle accident, or something like that. Okay. So that's just really important. I wanted to differentiate that. So emergent care. Okay, at this point, you're all about the airway, breathing, circulation. So that's why that fast, the T in fast, the timing is so important. And, you know, it got to the point where, as a public awareness campaign, they started calling this a brain attack instead of a stroke, because sometimes the word stroke doesn't elicit that fear. You know, when I say somebody's having a heart attack, people see, oh, that's really serious. The term stroke didn't necessarily have that same, you know, urgency. So when you say brain attack, that was kind of to make that connection and try to really help the public realize that, you know, seconds are brain tissue, minutes are brain tissue, is function. So it is really, really serious. So initially, assessment and diagnostics, they use the NIHSS assessment tool, your stroke scale. This is something that nurses actually go through specific training, that they can become stroke certified. It's usually part of the annual continuing ed competencies for most hospitals. It's a tool, it's several pages, but when you're trained, you can get through this very quickly. Basically, your patient's going to get a score anywhere from 0 to 42. The higher the score, the worse deficits your patient has, the more serious condition that they're in. So that the NIH stroke scale, that can happen very, very quickly. Our priority diagnostic test is the non-contrast CT scan. And this is all about determining the type of stroke, because I am going to treat medically, pharmacologic treatment, an ischemic stroke very differently than a hemorrhagic stroke. So at that point, when we're doing that non-contrast CT, what we're basically looking at is to rule out hemorrhagic stroke. If it's a hemorrhagic stroke, it's going to show up on the CT. We're going to be able to see the bleed, and that's going to dictate what we're doing. If it doesn't show up, at that point, it's the ischemic stroke, and we proceed down that path. So the goal is to get that CT scan done within 25 minutes of arrival. And a lot of your healthcare facilities now, EMS and, you know, the facility, have that radio communication. They have the wireless communication. So these facilities, if somebody's being brought in by EMS, they already have a heads up that we have a stroke alert. We have a patient with a possible stroke. And in many cases, they will actually divert the EMS directly to radiology first, do the scan, and then get them to the ER, depending on what the facility and EMS protocol is. But that priority is that non-contrast CT scan. And then once we rule out hemorrhagic stroke, okay, then you can proceed with the ischemic stroke protocol that you follow down. If we rule in hemorrhagic stroke, we're going to proceed down the protocol for hemorrhagic stroke. Regardless of which one it is, we are always looking at supporting the airway. So depending on the patient's level of consciousness, depending on their level of weakness, are they able to maintain their own airway? If not, do they need an oral airway? Do they need intubated? Okay, we want to support their oxygenation, their breathing. So if they're breathing on their own, we're going to support them with supplemental oxygen. If they're not breathing effectively on their own, we may need to ventilate for them initially with the, the bag valve mask, the ambu bag, all the way up to a mechanical ventilator. Okay. And then we need to support circulation. They're going to need IV access. We want to make sure they have fluids. Here's the thing. We need to balance this very carefully. We want to make sure they have what we call, that they're in a euvolemic state. They're not too fluid overloaded. They're not too fluid underloaded. Okay. We need to maintain blood pressure at a point that it is adequately perfusing the brain, but not high enough that it's going to put them at risk for a rebleed or a further stroke or an increase in intracranial pressure. Okay. So regardless of the type of stroke, those things are going to apply. The NIH stroke scale, that non-contrast CT, your ABCs, that never changes. Okay, that's just going to be here forever. Okay, let me check the chat box. I got a question. Can you have both? Yeah, usually it's one or the other. You can, in my dad's case, his was a hemorrhagic stroke. Which is obviously the first thing that they were treating. But when they did a follow-up MRI of him, it had actually shown that he had had multiple tiny ischemic strokes prior to that. At that point, when they do the CT scan, if they find a hemorrhage, that is going to preclude any type of TPA, anticoagulant, antiplatelet, anything like that, because that's just going to perpetuate the bleeding. So that's what the non-contrast CT is really looking for. It's not really looking to rule in an ischemic stroke. It's looking to rule out a hemorrhagic stroke, because the treatment that we're going to use for ischemic stroke, if we would give to a hemorrhagic stroke patient, it would kill them. We would kill them. So that's what we're really looking for. So if the CT rules out hemorrhagic stroke, so based on the symptoms, based on the NIH stroke scale, the CT ruled out hemorrhagic stroke, we're proceeding down the path of ischemic stroke. We might be able to use TPA, okay, which is essentially thrombolytic therapy. It is a clot buster. Think about Pac-Man. Pac-Man's eating the clot, okay? The whole idea of this is if we can dissolve the clot, we can reestablish blood flow. The sooner we can get blood flow and oxygen back to the tissues, the better off the patient. If we can do that in a relatively short period of time, within a few hours, we can significantly minimize the deficits that your patient would experience as a result of this stroke. Okay. Let me check the chat box here. So is it typical to lead to hemorrhagic stroke? Not really. So when we talk about strokes, what led to my dad's stroke was the uncontrolled blood pressure. So he had had uncontrolled blood pressure for years. So that increased pressure was causing that microvascular damage up in the small blood vessels. So that's where you were seeing, the lack of the vasoconstriction, vasodilation, and seeing the hardening of the vessels up there. Which is what was then causing some ischemia to distal places. But ultimately that pressure, so hypertension is a major risk factor for both. However, it is more common to have an ischemic stroke versus a hemorrhagic stroke. So getting back to the TPA, this will bust up the clot. This will eat away the clot, and the goal is to get the blood flow and the oxygenation back to the tissues that are distal to the blockage. Now, here's the thing, and I mentioned it before, benefit versus risk. It's always about benefit versus risk. So I put up some very basic criteria there for a patient to even be considered for thrombolytic therapy. Their non-contrast CT has to be negative. We also need to have a very specific known time of symptom onset, because TPA is given within 3, in some cases it can go up to 4.5 hours, but generally within 3 hours of symptom onset. And the reason we say that, okay, if I give a thrombolytic, whether it's within 3 hours or it's at 6 hours, it's going to break up the clot, okay? It's going to break up the clot. The reason they do the cutoff 3 to 4.5 hours is because the research has shown when TPA is given after that window, it doesn't tend to have as much benefit in reducing the deficits that the patient has. And the other thing you have to understand is when we give a thrombolytic, it is going to bust up any and all clots. Now, your body makes and breaks up clots all the time. So when we give somebody thrombolytic therapy, they are at risk for bleeding. They are at risk for hemorrhage. So in this case, when we're talking about an ischemic stroke in a patient that meets criteria, the benefit of reestablishing the blood flow at that point outweighs the risk of hemorrhage. Once we get beyond that 3 to 4.5 hour window, that risk benefit ratio changes, and it's much more risky for the patient. Okay, they're still at risk for hemorrhage, balanced with what benefit. Now we're beyond that window, they're likely not going to see the positive effects of reestablishing that blood flow, because the damage has likely been done. They're still going to continue to have deficits. So it's always about the risk versus benefit. These patients who are on thrombolytics, if they are candidates, we get them started right away in the ER, okay? Ultimately, they're on thrombolytics. They need to be in the ICU. Really, if there's a specialized stroke unit, they should be on that type of unit. These patients are going to be on continuous cardiac monitoring. They're going to have very frequent neurological and vital sign assessments, because here's the thing, risk versus benefit. Our goal with thrombolytic therapy is to bust up that clot and reestablish blood flow. But one of the big risks for this is we can go from an ischemic stroke to causing a brain bleed, okay? So again, that window is very important. That frequent neurological and vital sign assessment is critical, because you will see changes in their neuroassessment if they're developing a complication, if they're developing now a bleed. If they're not having a complication and the medication, we're getting the results we want, we're reestablishing the blood flow, you should see changes in their neurological status, but improving changes. Okay, so it's very, very critical that we are very closely monitoring this patient and trending their results, trending their assessment findings. And that's why I spent time at the beginning here talking about assessment findings. Now, in your critical stroke patient, we are not doing cranial nerve assessment. We are not doing mood, judgment, insight, all of that. We're really looking at Glasgow Coma Scale. We are looking at, basically their level of consciousness. We're looking to see their response to reflexes. We're looking to see their vital signs. Are we seeing changes in that? Very, very closely, because if your patient starts deteriorating when we've put them on thrombolytics, we're going to stop them and then we're going to rescan them and hope that we didn't cause a hemorrhage. But that is a known risk of TPA. When they go in and talk to the patient, when they talk to the family, and they get that informed consent for TPA, they go over the potential complications, and hemorrhage, including a brain bleed, is one of those potential complications. Nothing we do is without risk. So that's where that risk benefit consideration is so important. Okay, but as you can see, if we did not rule out hemorrhagic stroke, okay, just think about this for a minute. Patients had a hemorrhagic stroke. The body is trying to correct the problem, so it sends platelets and clotting factors to the bleed to plug it up. Oops, somebody didn't get a CT scan, or we didn't read it correctly, or something happens and that patient got TPA. That medication is going to bust up that clot that body just made to try to stop the stroke. Okay, so that is why it is so critical, that non-contrast CT, to be able to rule out hemorrhagic stroke. Okay, very, very important. So looking at these medications, and I've kind of already talked about the thrombolytic therapy, but at that point, all of these, whether you're talking thrombolytics, anticoagulants, antiplatelets, these patients are going to be at risk for bleeding. Okay, there's baseline labs that we have to get. These are generally going to be part of your standard ER protocol if you have somebody coming in as a stroke alert. Or we assess them very quickly, triage them, we're thinking stroke, this is in the panel. I mentioned the frequent neurologic and vital sign assessments, watching for signs and symptoms of bleeding. We certainly don't want to do anything to the patient that would cause bleeding. We want to watch venipuncture. Obviously, these patients are going to need IV access. That is put in before we start TPA, but it is not uncommon to see some sanguineous drainage oozing from around that IV site insertion, or if they have a central line insertion. So we want to avoid any type of additional venipuncture and injections if possible. If they develop massive bleeding, they're having a severe hemorrhage, we're going to have to respond to that. So having whole blood, packed red blood cells, fresh frozen plasma on hand at the hospital to be able to deal with that in an emergency situation, that's a standard. For your thrombolytic therapy, aminocaproic acid, that's your reversal agent. In this case, again, we go to that, here we don't really consider an overdose on a thrombolytic therapy. We're giving thrombolytic therapy to dissolve the clots. If we start seeing hemorrhage, we're at the point that this is life-threatening for the patient. At that point, you stop the TPA, you infuse the saline, and we're giving the reversal agent. The TPA, honestly, when we talk about a lifespan issue for your, gosh, I can't think of the term, but how long it lasts in your body, it's not very long. So your body does quickly go through it. But in the meantime, it is not uncommon for them to get a dose or two, at least, of the aminocaproic acid to try to counteract that effect. I also have GI prophylaxis on there, because the two big areas we worry about bleeding, certainly neurologic hemorrhage in the brain, and then also GI bleeding. So these patients are going to be on an IV proton pump inhibitor, perhaps even an IV proton pump inhibitor drip, not even just IV push. They might be on a drip. As we talked about with the last unit, the aspirin, we might use aspirin in a patient that is not a candidate for TPA. Or maybe they have received TPA as their initial treatment. We wait for that to kind of, do its thing. And then several days later, they may be started on the aspirin. The aspirin itself essentially is just to prevent clots from getting bigger. It's also to prevent additional clots from forming. It's all about keeping the platelets slippery. It makes them harder to stick together. So again, if your patient's on aspirin therapy and enteric-coated tablets, you want to take them with food, they're likely going to be on a PPI or an H2 blocker. Of course, we're always looking for signs and symptoms of bleeding, ecchymosis, petechiae, the bruising, the bleeding gums, any blood in the urine, blood in the stool, blood in the emesis, anything like that. And then, of course, with aspirin, we know long-term therapy puts them at risk for hearing loss. So we might want to be, monitoring for that. But then again, you're looking at, okay, recurrent stroke versus I lost some of my hearing. What's the lesser of two evils? The anticoagulant therapy, this is all about interfering with the clotting cascades. And there's different medications I have listed there. You do not need to know what exact factor. Sorry, my cat's like wheezing here, and I thought you could hear her, so I had to wake her up. Your anticoagulants, I don't expect you to know what factors they affect. I want you to understand that they're going to interfere with the clotting cascade, and it's going to essentially make the blood take longer to clot. Okay. You already know, we covered in the last unit, the reversal agent for warfarin is going to be your vitamin K. Your reversal agent for your heparin is going to be protamine sulfate. I do have enoxaparin written there, but honestly, we're not using protamine sulfate unless we're reversing true IV heparin. Okay. All right. I see some questions in the chat box. So before we move on, let's see here. Is it? Okay, I think I answered that. Auscultate lung sounds, I don't know, check your ABCs. I'm not quite sure where you're going with that, but yeah, obviously ABCs are always going to be, a big thing there. Looking at that. Oh, the cat, I should check her ABCs. Well, actually, we'll just take a little break here. Hey, Casey, wake up. See, she's right there and she wheezes. She's a calico and like she just does that. But she sounds like Darth Vader. Oh, not you, Casey Rambo, that Casey. Anyway, she sounds like Darth Vader, and sometimes I literally think you guys can hear her on there. And she always sits there. Sometimes she'll walk behind me. But anyway, her airway breathing and circulation is intact, but I think it's the way she sleeps. She kind of cranks her neck and she kind of sounds like Darth Vader. So, you know, she's good. All righty. Sounds good. Let's keep on moving on here. So acute care for a hemorrhagic stroke. As I mentioned before, they're going to present very similar to the ischemic stroke. Things that will be specific to hemorrhagic stroke are going to be that severe headache we talked about. There usually tends to be some sudden changes in level of consciousness. And if the intracranial pressure is going up, you're going to see potentially projectile vomiting. And this isn't just, this is like they're puking and literally it's hitting, you know, several feet away. To diagnose this again, we're looking at the CT scan. Again, we want to rule out hemorrhagic stroke with the idea that maybe we could use TPA. In this case, obviously, we're ruling in hemorrhagic stroke. Cerebral angiography is used if the CT scan is showing something like an aneurysm, okay? That there is a source of the bleed in the sense that there's an aneurysm. They can sometimes do the cerebral angiography to try to coil the aneurysm, to try to stop the bleed. Many times, like in my dad's case, there was no aneurysm there. It was just the uncontrolled hypertension, and he literally got into a hypertensive crisis, and it was high enough that it just ruptured the vessel, okay? Lumbar puncture if the CT is negative and their ICP is not elevated. So there was a question in the chat box earlier, well, why wouldn't you do a lumbar puncture? Because you can help drain off spinal fluid. And that is true, you can do that. However, that initial insertion of the needle, okay, into the spinal column, into the area where those, the fluid is, that is actually initially going to cause a rapid spike in ICP, just that initial thing in there. Now, it will come down on its own. Like if we do a lumbar puncture on somebody with suspected meningitis, we're looking at the benefit versus the risk, okay? The benefit of getting the CSF sample so we can test it and figure out what's going on versus the risk, yeah, it's gonna cause an increase in pressure. If your patient's pressure isn't already elevated, they can tolerate that quick increase in pressure and have it go down. If your patient has a hemorrhagic stroke, you know, and their pressure is already elevated, depending on how high it's elevated to begin with, if we do that lumbar puncture, you cause that rapid increase. In a serious case, you could cause a brain herniation. You can literally cause the pressure to increase so much that the brain herniates down on the brain stem and essentially kills them. So that's where the lumbar puncture is a little bit iffy. That's really going to be up to the provider, whether they really feel the need to do that. Generally, they'll do the CT scan. They can consider cerebral angiography. You know, again, and there was a question about, well, why would you want to use dye with the cerebral angiography? Won't that cause harm? It absolutely can cause harm. But if the bleed is at their aneurysm and we don't clip and deal with the aneurysm, they're not going to get better. Things are going to get worse. So again, you're always going back to that benefit versus the risk. And when we talk about a stroke, you have the acute nature of the stroke, this sudden onset, this initial urgent, emergent, acute care that we're dealing with. But what we do in those stages are really going to set the tone for the long-term prognosis for this patient. You know, okay, we keep them alive, they survive. What kind of deficits are they going to have? Are those temporary deficits? Are they going to be able to come back from those? Or are they permanent deficits? And how does that affect their activities of daily living? How does that affect their quality of life? So these stages are just very, very important. What we do initially is going to make the difference. So with a hemorrhagic stroke, unfortunately, there's not a lot we can do. Care is primarily supportive. If it is an aneurysm, we can do the angiography, we can clip the aneurysm, coil the aneurysm, you know, we could do that. If it's not an aneurysm, basically we want to kind of control the blood pressure. We want the body to use its own resources to essentially stop the bleeding. Now, here's where we look at a problem. You know, depending on how much blood is out in the brain tissue, that blood will eventually be reabsorbed into the vasculature. It takes, you know, several weeks, months for it to completely reabsorb. However, depending on what amount of blood is out there, that's causing increased intracranial pressure. So they may have to go in there and actually, you know, do a burr hole, or they may have to go in externally to drain that blood. Or if you have brain swelling, because remember, again, if the brain's swelling, it can't go past the skull, it's going to swell down on itself. So if you have a massive elevation in ICP with brain swelling, they may go in just like they do with like head trauma or from a motor vehicle accident. They might go in and actually remove a portion of the skull to allow room for that brain to swell. Okay. But for the most part, a lot of time hemorrhagic, the care is just supportive. We're supporting their oxygenation, their perfusion, their nutrition, getting that blood pressure under control, and we're basically letting the body heal itself. Okay. The surgical procedures that are there, the ventriculostomy, this is something that they can do. They can put into, if you remember back to your anatomy and physiology, your brain has 4 ventricles, that they can actually put a device in there that connects externally, and they can drain off excess cerebrospinal fluid. It might be used for stroke. Where you really see it used more for is head trauma, you know, your motor vehicle accidents, your traumatic brain injuries with that. But again, this is mostly supportive. You know, in my dad's case, what they did, they essentially sedated him. I mean, he was, we call it, you know, it was a sedation vacation, but they basically sedated him. He was paralyzed, he was on a ventilator, and we were supporting all of his bodily functions, all about trying to control the blood pressure so the hemorrhage could control itself. You know, there was no aneurysm. It wasn't a large enough area that it caused a significant rise in ICP. And even if it had, his particular location of where his stroke was not an operable site. Okay, he was down by the thalamic artery. That's where the rupture was. So it also depends on location of what you're going to see and what we're going to be able to do. Yes, if you don't know how to type a question, unmute yourself and ask your question.
Like when you have an aneurysm, I thought like once it started bleeding, it was considered a hemorrhage. Is that not right?
No, that is correct. If you can have an aneurysm, once it's bleeding, and that is, and in the head, that is considered a hemorrhagic stroke. Okay, but you can have somebody that has an aneurysm that is not bleeding. In fact, a lot of people with cerebral aneurysms, it depends on how the aneurysm developed. A lot of times there are genetic factors that people spontaneously develop aneurysms, and sometimes they're getting a CT for something else and they discover the aneurysm by accident. Okay. Other times, you know, in many people's cases as well, over the years of high blood pressure, you might have a weakening of that arterial wall and have an aneurysm develop. Usually you see that more so with like your aortic aneurysms or your thoracic aneurysms. If we're talking a cerebral aneurysm up in the brain, generally those are a genetic thing. And a lot of times they may have been there since birth. It could have been congenital, but it didn't cause a problem until it ruptured. You know, unfortunately, when we talk about an artery rupturing, because the arteries are high pressure, they tend to bleed very quickly. So if you have somebody with an aneurysm, particularly like an aortic aneurysm, if they have an aortic tear, it really depends on how big that tear is. If it's a major tear, even if it happens in the hospital while they're there, their mortality rate is really high, their risk of death. So great question. All right. So ongoing care, once we get past that initial urgent care, We're always supporting the ABCs. We're still doing the frequent neuro checks, the cardiac monitoring. For our ischemic stroke patients, I mentioned this earlier, if they were not a candidate for TPA, they generally will start them on aspirin. Years ago, we used to have them on anticoagulants all the time. Newer research has shown that that's not necessarily more beneficial than using the low dose aspirin. So it kind of can be either or. It's really going to be very dependent on the provider. We want to watch their temperature, and this kind of goes a little bit more towards hemorrhagic strokes, but you can see it too with ischemic strokes. As you have brain swelling, or if the damage is down in the hypothalamus, the thalamic area, you can see issues with them managing their temperature, either their temperature, core temperature going high or low. We get concerned if the core temperature is high because that can cause seizures. And of course, seizures, if you have a hemorrhagic stroke, that's a great way for your patient to rebleed at that original bleed site. So we're very careful with temperature of these patients. It's not uncommon for them to have acetaminophen suppositories to control their temperature. A lot of times they are also on anticonvulsant medications as a proactive thing to prevent seizures. It's also very common that as people are recovering from strokes, that they are continued on an anticonvulsant medication, at least for a period of time after that stroke. Okay. All right, here we go. If they can't have TPA, are the outcomes similar with aspirin? Okay, so aspirin, we're all about preventing the clot from getting bigger or additional clots from forming. The TPA, the goal is to actually bust up the clot itself and reestablish the blood flow. So with aspirin, yeah, they're still going to have damage. We're not going to be able to reverse, what was happening. Our goal is to keep that damage from getting worse and really look at preventing recurrent strokes. That's really the key. And when we talk about TIAs, or transient ischemic attacks, mini strokes, I like to liken these as California, where they have little tremors, little tremors, little tremors, and then you have the big earthquake. Okay, the big earthquake is your stroke, your CVA. Those little tremors are your TIAs, and they are warning signs. They are warning signs of an impending major event. And that's why it's so important if you have patients that come in with stroke symptoms, but they resolve within 24 hours or so, that's a TIA, and that's a ticking time bomb. We need to take appropriate action. What are their risk factors for stroke? Let's address the modifiable risk factors for stroke to reduce the chances of that happening. Proactive care, prevention is really important. All right, so while we're dealing with these patients, our goal is to maintain their cerebral perfusion pressure, which is just a big fancy term right now for making sure we're getting adequate blood flow to the brain. Okay, I need enough of a blood pressure to perfuse the brain, but I don't want it too high that it's going to elevate intracranial pressure. So our goal for these patients is for their blood pressure to be 140 to 180. Over about 80 to 105. And that is a really, really critical thing. And sometimes when you have somebody like my dad, his blood pressure in the ICU, he was up in the 220s, 230s. And we were trying like heck, different IV medications. He was on a propofol drip to knock him out for the ventilator. But it was really about reducing that blood pressure. Now, of course, you can't take them from 240 down to 180 that fast, okay? Remember, we talked about last unit, that hypertensive urgency, you're looking at reducing 25% in the first, 6 hours. But it's tough. You want to get their pressure down because we want to reduce their risk of rebleed or, having more damage. But you need it high enough that you also are perfusing the brain. So all the medications we're using here are going to be IV. That was one of the reasons they had him sedated, completely sedated out on the propofol drip, because at that point we're supporting all his bodily functions. We're trying to make his body use the least amount of energy as possible, because as you move around, that's going to increase your pressure as well. we'll use diuretics, in particular mannitol. It's an IV osmotic diuretic. Again, we're trying to get that blood pressure down. We want to have a normal sodium level, because if your sodium levels are off, it will cause shifting of fluids between the cells and the interstitial space. And we don't want that. We want the cells to be as stable as possible. Head of bed will be elevated to promote venous drainage. We want to keep their head in a neutral position. If their neck is flexed, that hinders drainage. Okay, and that can also increase the pressure. So head in a neutral position. Want to be very careful with that. Glucose management, again, their body is in a life-threatening situation. So it needs energy. So we want to make sure we're maintaining their glucose between about 140 and 160. And then for your hemorrhagic stroke patients or patients that have a known aneurysm, we're trying to prevent a rebleed. We institute what we call aneurysm precautions. And there's a table in your textbook that talks more about that, but essentially these patients cannot do anything. Anything that would raise their blood pressure is going to put them at risk for that aneurysm rupture. So calm environment, lights dimmed. We're not doing any real invasive procedures at this point. Everything is just very, very gentle. We space activities apart because they can't handle an increase in pressure for a long period of time. It's just really, really critical because we don't want that rebleed to happen. And we generally do that for about 3 to 5 days. We also use aneurysm precautions preoperatively. Let's say a friend of mine, actually, she had gotten a CT of the head for something else. She was having chronic headaches and it ended up being migraines or whatever. But during that CT of the head, they actually discovered she had an aneurysm. Now, the aneurysm wasn't what was causing the problem, but they discovered it there and they wanted to be proactive and fix it before it became a rupture. So for her, they did that. It was an elective surgery, but they did it fairly quickly within a couple days. But she was, advised on an aneurysm precautions prior to that because we wanted to prevent a bleed in the first place. Okay. All right, so recovering, we have that acute phase where we're treating the acute blockage or bleed. We're supporting care, and we're also beginning actions to prevent potential complications. We often say stroke, it's all in the head. It's a neurological thing. The reality is when your patient has a stroke, it affects every single body system in their body. Okay, it affects every single one. So we need to start thinking about, okay, we're transitioning from focusing on survival to function. Okay, how do we prevent complications? How do we promote function of all the body systems? And that starts after that emergent phase. It starts in that acute phase. And then they move on, once they're stable, they move on to the rehab phase, which is where we're really focusing on promoting client function, self-care, minimizing deficits, communication. This rehab phase, obviously this is the longest phase. They kind of continue with it for the rest of their life. But the reality is your stroke patient, whatever function they regain in the first 18 months after their stroke, that's probably the best they're going to get. Okay. Usually we're looking at 1.5 years to maximum to rehab. If it's not back after that, it's probably not happening. Okay. Okay. So I know you guys like NCLEX items, and I have a special one for you. It's a select all that apply because I know you love them. Okay. So when providing community education about stroke prevention, which information is included about modifiable risk factors? Okay, modifiable risk factors. Okay. What do you mean, yuck? Oh, you love select all apply. Just put your answer in the chat box. Okay, what are you going to do here? All right. Oh, there we go. ABC. Okay. Yeah, because what are your key terms up in the question? We're looking at stroke prevention and what kind of risk factors? Modifiable ones. So can you control your blood pressure? Can we do that with diet, exercise, and meds? Sure, we can modify it. Now, your patient is always going to have that diagnosis of hypertension. please understand that that diagnosis is never going away, but we can control their blood pressure to reduce the risk. Limiting tobacco use, especially cigarettes. Yeah, that's a good thing. Remember, we talked about in peripheral vascular disease, smoking, okay, and nicotine in particular, but smoking is going to cause vasoconstriction and vasospasm. Both of those increase the risk for stroke. So definitely, you know, altering the tobacco use. Maintaining a healthy weight and BMI. Well, think about the plaque buildup that's on there. Why does that happen? Obesity, high fat diet, high triglycerides, high cholesterol. So those things would all be there. And I'm not sure how that got in there. African Americans are at higher risk for stroke. I probably would have worded that differently, but yeah, you can't change your race. You can't change your gender. You can't change your, well, you can't change your biological sex. You can't change your age. Okay. So those things are considered non-modifiable risk factors. I can't do anything about that, but I can, and I should do something about my ABCs. Okay. All right. Let me check the chat box here. Oh, what? Okay. What is ASA? ASA is aspirin. AVM is arteriovenous malformation. And AVM is very similar to an aneurysm in the sense that instead of being very distinct arterioles and venules, they're all kind of together in like a massive mess of a ball of vessels, and their vessel walls tend to be very weak. So AVMs are considered a type of aneurysm, and they are prone to rupture. Hemodynamics just refers to, is your heart pumping effectively to perfuse your body? Do you have enough circulating volume to perfuse your body? When we talk about somebody, if they have unstable hemodynamics, they either have a problem with the pump, with the, you know, with the heart, or they have a problem with the pipes, which are your vessels, or the fluid that's inside the pipes. So when we talk about somebody being hemodynamically unstable, at that point, their body is not able to support perfusion, oxygenation and perfusion. So good questions. All right, NCLEX item number 2. Which action should the nurse take when working with a client status post right-sided CVA who is experiencing homonymous hemianopsia when eating? All right, this one might be a challenge because if you didn't look through all the stuff for today, you might not know what that is, but that's okay. We're going to walk through it. All right, your options: provide a non-skid mat to minimize the plate movement, encourage the client to use right hand while eating, prompt the client to look for food on the left side of the tray, and provide wide grip utensils. Okay. Before I go any further in talking about this, A, B, C, and D all sound like interventions that are appropriate for a stroke patient. Okay, they are. In fact, they were all things that they did for my dad. But what is the question asking? Okay, what is the question asking? Okay, we're talking about a right-sided CVA. So if it's a right-sided CVA, it's affecting the left side of the body. Okay, all right, they have homonymous hemianopsia. Okay, well, you know what hemi means. It's referring to one side. Opsia, we're kind of getting into the vision stuff. So even if I didn't know exactly what this was, it's something related to vision. They have some sort of visual deficit. So what am I going to do to address that while they're eating? Okay, is the non-skid mat going to make a difference in supporting the vision? No. Is him using his right hand going to help while eating? It'll help, but is it going to address the vision? No. Prompt the client to look for food on the left side of the tray. Okay, well, now we're talking about vision. I kind of like C. Provide wide grip utensils. Well, I'm going to do that, but again, does that address the vision? No. Okay, so the correct answer here is C. So again, all of those things are going to be used for my post-stroke patient, but which one addresses the problem that is presented in the actual question? Okay, so again, this goes back, and I'm going to do another plug for Nurse Logic, please. Okay, get on there, because really looking at how you approach these questions and how you interpret what the question is asking really can lead you to the answer, even if you had not a complete clue as to what that term was. Okay, so I cannot emphasize nurse logic enough. Oh, what is nurse logic? All right, I'll follow up with you individually, but nurse logic is on ATI. It is on there the same way you would get to your skills modules, but it's a special thing on there, and it's all aimed at how to approach test questions, how to develop your nurse brain, your thinking. So there's different pieces there. There's priority setting, there's critically reading test items, but there's a section on there about clinical judgment and clinical reasoning and developing that. And that is really important, not only to help you as a practicing nurse in taking care of your patients, but the immediate need to kind of help you with the exam. Okay, got to make it applicable. All right, NCLEX item number 3. In which order should the following items be carried out for a client admitted with a suspected stroke? So here you have to put them in order. If you were doing this question on ATI or NCLEX, it would be a drag and drop format. So very similar to your interactive case studies with Hinkle and Cheever, where you're having to drag and drop. So thinking about, I'm going to do all 4 of these things. I have to put them in order. So throw them up there in your chat box and we'll take a look. I got to figure out how to do polls and stuff. I haven't figured that out. Maybe I'll figure that out by the end of the semester, but you know, whatever. All right. Okay, so I'm seeing some people want to do C first. Some people want to do B first. Okay, most people are okay with A and D being last, but the question is between the B and the C. All right, well, let's see. If you picked B, C, A, and D, you are correct. Okay. Now, I'm going to go back to the question and let's kind of talk it through. Okay. Determining the time of symptom onset. Okay. That is important. However, if it is a hemorrhagic stroke, which I would determine based on the CT scan, option B, if it's a hemorrhagic stroke, does knowing the time of symptom onset change your treatment plan? And the answer to that is no. So when you look at this, the most critical thing I want to do is determine, is it an ischemic stroke or is it a hemorrhagic stroke? Or really, I want to rule out hemorrhagic stroke. Because I am assuming at this point, my TPA, I'm going to be doing it because it's the A there as an option, but I need to rule out that hemorrhagic stroke. Not that I don't care when their symptoms started, if it's a hemorrhagic stroke, it's good to know. I'd like to know, when it kind of started, as to determine how long, he's been without that oxygen, but it's not going to change the pharmacologic treatment. It's not going to change the plan of care like it would with an ischemic stroke, because if we don't know the time of symptom onset, or we do know the time of symptom onset and it's more than that 3 hours, TPA is not going to be an option. So the correct thing would be to do the CT scan first. So we have to verify the type of stroke to even determine if they're the candidate. Yes, it's ischemic. We've ruled out hemorrhagic, so we're thinking ischemic. Okay, now, what is the onset? That's going to determine whether or not we're a candidate for TPA. Okay, we are a candidate for TPA. We want to go ahead and get that started. We're going to start it right away in the emergency room. Once we determine that they are a candidate, then we're going to get them up to a specialized unit. Because as nurses in the ER, not that they don't hold critical patients in the ER, but it's not the best place for them. Okay, these patients really, with the close monitoring that they need to be in an ICU level care. They need to be with those critical care nurses. Okay. All right, let me check out the chat box here. Asking a question versus transporting to CT machine, it would seem that would be first. Okay, I'm not quite, I think I sort of know what you're asking. I think you're talking about the NIH stroke scale. That wasn't an option on there. The stroke scale generally can be done really quickly. But again, what is the stroke scale going to tell you? It's going to give you a number from 0 to 42, which will classify the severity of the stroke. But is that going to determine whether or not you can give TPA? Okay. Ask them when the symptoms start. It's not part of the NIH stroke scale. You know, with the symptoms started, that's not going to really alter care. Our biggest thing when we're suspecting a stroke, your priority is to do that CT scan, the non-contrast CT scan. And that's actually why a lot of our EMS now, because they're in contact with the facilities, and we know there's a stroke alert en route, and they are actually many times redirected to radiology to get that scan immediately before we can start treating them. Because the sooner we get that done, the sooner we're able to determine, you know, what type of stroke it is and go from there. Just to comment on, I feel like you will know when the symptoms start by report. It kind of depends. You might know based on the family report, but the other thing you need to consider is you need to be able to specifically determine. And there's a difference between, you know, I woke up okay, I'm doing all right, I'm sitting at the breakfast table, and all of a sudden I start having symptoms. I have a very specific onset of symptoms versus you saw me last night, I was doing perfectly fine. I woke up this morning and I already have slurred speech, confusion. It happened sometime during the night. They can report that they found me that way, but I don't have a specific onset of timing of the symptoms, okay, because I have that window there. And that's really important when it comes down to TPA because of that benefit versus risk ratio. You know, yeah, I woke up that way. It could have happened within the last 3 hours, but I don't know that. And they can't determine that. So at that point, if that had happened, I would not be a candidate for TPA simply based upon that. So just something to really understand with that. And the last thing I want to do here is just kind of, you know, introduce this in relation for our next Zoom on Monday. This exercise, this slide and the next one are actually taken right from the class PowerPoint that's on there. But there is a patient scenario there, talks about him. You probably figured it out from talking here. This is my dad. This is essentially his case study boiled down into 2 slides. But where I want you to look at and where we're going to pick up our discussion on Monday, because it ties into the other chronic neurological disorders, is looking at that rehab piece. And I want you to think about and complete that online worksheet for this class, the U6C1 online class worksheet, because this exercise is on there. But I want you to think about how the stroke impacts the body systems that are there. Okay, and think about interventions that we're going to do. Okay, and they can be collaborative. It doesn't have to just be nursing. It can be PTOT. You know, it can be the dietitian. It can be the speech therapist. But thinking about interventions that relate to each of those body systems that are aimed at preventing complications, okay, or maximizing function, or both. Okay, so that's kind of where we're going to pick up with that. And just to show you, this is just a screenshot or a cut off of the worksheet. I asked only for 5 and I kind of grouped them together. If we were on campus, what I would have actually done is break you up into 8 groups, and each group would have done a single body system with like 10 interventions. But I want you kind of thinking about, okay, well, what are we doing for this patient in relation to their stroke to prevent complications and maximize functioning of that body system? So I put cardiac and respiratory up there because we just finished oxygenation and perfusion. But think about your patient who's had a stroke. Why are they at risk for respiratory complications? What can we do about it to prevent them? You know, think about respiratory complications perhaps related to swallowing and aspiration. Think about respiratory complications in relation to decreased mobility, that they're not moving around a lot. What happens to your respiratory secretions if you're not moving around? You know, how does atelectasis turn into pneumonia? You know, thinking from a cardiovascular standpoint, certainly we have the cardiovascular piece of addressing the stroke risk factors to prevent a future stroke. But again, they're not moving around. What does that put them at risk for from a cardiac perspective? And just really looking at each of those body systems and focusing on preventing complications and maximizing function. Okay. All right. let me hit back to the chat box. I'll be addressing questions here, and then we'll kind of wrap it up. I know we went a little bit longer. Once we're done, I'll take like a 10-minute break, and then I'm going to do a CP3 Zoom session. Again, that'll be recorded and uploaded if you can't attend that. All right, we got a large chat box, so let me start back at the top to make sure I didn't miss anything. Cerebral angiography with the aneurysm. Wouldn't the contrast dye leak out into the brain tissue CSF? Yes, it can. And at that point, again, we're looking at the benefit versus the risk. We did talk about lumbar puncture increasing the ICP. Oh, how is ICP measured? Very good question. So this is definitely advanced neuro. So what they essentially do is they will insert an ICP monitor through the skull. They'll actually, drill holes into the part of the brain and be able to insert the ICP monitor. There is a dressing over top of the insertion site. Obviously, it's a sterile procedure, sterile care, and that sort of thing. So they can use that both to measure ICP, and if it's a ventriculostomy measure device, they can actually tap off CSF fluid. Again, not so much seeing that with your hemorrhagic stroke. That would be more with your traumatic brain injury, brain trauma, motor vehicle accidents, that sort of thing. Okay, we did talk about AVMs. Okay, very good. With hemorrhagic strokes, are the patients on bed rest to prevent a rebleed? Yes, they are on. So your hemorrhagic strokes will likely be completely sedated. So they're on bed rest, they're not moving around. Your ischemic strokes, initially they'll be on bed rest. Again, that will help manage the blood pressure. But again, remember, we have to balance that. What is the risk of decreased mobility and how that affects the patients? So if they are on bed rest or limited mobility related to ischemic stroke, hopefully we've already started that aspirin or potential anticoagulant therapy. If, I will say, a lot of times they'll go with aspirin if the cause that they can track is something like AFib, where the clot was formed in the atria, went to the ventricle, and then got pumped up. They will likely go straight to the anticoagulants versus the aspirin. Otherwise, aspirin is usually what they want to go with that. But yeah, so ischemic stroke patients, you have that initially we're trying to control the blood pressure, but we want to balance that risk versus benefit of that decreased mobility. The other thing too is activity limitation. We also need to know what their deficits are. So they need to be evaluated by physical therapy, occupational therapy, see, what their deficits are, what their safety issues are. My dad had to learn how to walk again. He literally had to learn how to walk again. And he could not get out of the bed by himself. He went from initially being a complete lift to a standing lift to eventually today he's able to walk with a walker, and that's pretty good from considering it, at one point, we didn't know if he was going to make it. It was very touch and go. Okay, how often are the vital signs and assessments taken for a patient that had a stroke? Generally, at a minimum, they're going to, or at a maximum like that, they're going to be every 4 hours. If it's somebody that's up on a basic telemetry or a med surge with telemonitoring unit, if they are receiving TPA, they are sedated, they are vented, they're in the ICU. So at a minimum, there'll be vital signs every hour. If they're TPA, you're probably looking at vitals and neurochecks every 15 minutes, okay? But very, very frequently because we're looking at those subtle changes. Let's see here. I talked about that. Okay, now we're into the exam thing. Let me get back to that, posturing. Okay. Now we're on the cat, okay. Okay, I'm just going down here. I just want to make sure I've addressed all these questions. We talked about nurse logic. Talked about transporting. Oh, okay, here we go. Now we're to the bottom here. If no one knows upon arrival exactly when the symptoms started, how is that determined? It's not. And at that point, we assume that they're outside of the window. If we cannot pinpoint that, then right off the bat, they're going to be disqualified as a candidate for TPA. Will you be making the Google games again as well as the prep test? Yes. So I'm for sure doing the custom ATI assessment. The Google games focus mostly on pharmacology, but students seem to really like those. There's not as much pharmacology on this particular exam, but I think that type of learning can also be used for things other than pharmacology. It can be used for like priority assessment, so I will definitely do that. And I'm working on a Jeopardy game. I'm working on Jeopardy. Could you do it, cranial nerves? I could, but my goal for those things is to kind of put things that might be more beneficial for the exam. So you know, I want to choose my things wisely, if you understand what I mean. But yeah, so, and I'm working on a Jeopardy game because based on student feedback, that seemed to be very helpful. And based on the overall group exam scores, it seemed to be very helpful. So I was pretty pleased with that. So, all right, any last minute questions on this? In preparation for Monday, do make sure you go on and do that online class worksheet from class 1, because we're going to talk about this last piece, those interventions with the body systems, and that's going to tie in very nicely to MS, myasthenia gravis, Parkinson's, and ALS. Okay. Any last minute questions? No? Okay, well then I'm gonna stop sharing here and I will sign off and say we'll see you hopefully in 10 minutes when I start the CP3 Zoom. Otherwise, I'll see you Monday. Okay, have a good weekend.